Thank you, Professor Sejana. So we'll just now start getting into some of these questions, and then there are microphones in the audience for those of you who have other questions. So I think what this session this morning has done is really highlighted that despite all the advances in endovascular therapy and imaging and surgical management, critical care management, this is a very, very high-risk group of patients, continues to have very, very high 30-day mortality. Long-term mortality remains high. The diagnosis remains elusive. And, clearly there's a lot of additional work to be done, and our understanding needs to continue to evolve. One question I had for the panel pertains to the use of imaging, and we've seen a lot of advances in stroke imaging and specifically four-dimensional perfusion imaging of stroke imaging with CT technologies. Does anyone see a role for that in this indication and when the clinical suspicion is high, but the biomarkers and lactate and so forth may be nonspecific? Is there a role for this, or is that just, are we still going to be stuck with looking for bowel hyper-enhancement, hypo-enhancement, and so forth?
I'll take that. Yeah, no, I think the approach to the individual with the acute abdomen and the imaging approach is it is going to change as we get more facility with these perfusion imaging technologies, but it's a ways away to really validate that, right? And I think the key thing again is early consideration of diagnosis and imaging, because you're just looking for an occluded SMA. It's not necessarily the bowel findings, but if you see what's an obvious occlusion of a central visceral artery, it can really help direct the therapy. And there is some literature that suggests, I think it's particularly out of England, that depending on what your initial consultation is in the emergency room, if you have a surgical consultation, you're more likely to more quickly get to the correct diagnosis and you have a better outcome than if you kind of wind your way through a more leisurely type of approach. So yeah, I agree. I think that's going to be critical, but we're probably a ways away from that, and it's just the focus should be on early consideration of the diagnosis and getting the right people involved to think about it.
If I may, I also add something, is that it is very true that we should, to some extent, look for some parallel between stroke treatment and acute mesenteric ischemia treatment. But as it was said, probably imaging modalities should not really be the same and give the same information which we are looking for in stroke and in ischemic mesenteric ischemia. What we want to achieve as soon as possible with the diagnostic tool is just the patency of the vessels, not so very much as perfusion through the wall of intestine. But it is very true that it is so very important, I think, is a matter of a time window to make all clinicians more aware that the patient should go far more faster with diagnosis, and therefore this multidisciplinary approach is so crucial in these situations, because it will definitely probably change the possibility for the patient to get a faster diagnosis and then faster treatment and finally better outcome.
And one of the other questions we had on the app really follows on from that concept, and it's addressed to Carlos. When do you decide, when you receive a referral for one of these patients, that you would recommend endovascular recanalization with interventional radiology, and when would you decide when to operate?
Well, in general, if we are called, we normally have an image right after or very soon. And we actually go and discuss with interventional radiology. If the patient is not peritonitic, that I know that I need to do something with the bowel, probably would ask them to go first for reperfusion, and they would go second. Yeah, that would be like a clean cutoff. The rest is, I think, it's just based on discussion. If it's perforated, for example, it's obvious, like, But if there's not very clear bowel, or we don't know the extension of the bowel injury, we go first for the reperfusion.
Another question for the panel, and this may be beyond the scope of the discussion, but in our own institution, we've had instances where we've been consulted for an endovascular first approach for acute mesenteric ischemia, and this has been done in conjunction with GI hepatology, GI surgery, and the patient has not had a laparotomy. So we don't know the status of the bowel beyond the imaging findings, which suggest the bowel's still viable. There's no free air. So we've revascularized those patients only on the contingency that they then go for a laparotomy. So then we'll place the SMA stent, and then we say, okay, now it's up to you folks. And then we're told now the patient's too ill to go for laparotomy. And so they continue to be managed expectantly, and then have presumably areas of non-viability, develop sepsis, and then succumb. Has that been something that people have found problematic with endovascular first? Do you really need to have always laparotomy first, then endovascular approach, and then second look laparotomy?
I think that's the gospel. Is you should revascularize and then, in conjunction with surgery, have a look, and then even a second look if you have a first look. But things change. I mean, you may be done by the time you get revascularized. You have to be fair. The patient's condition may change dramatically in an hour or 2 hours, depending on when you're getting to them, and they may really no longer be a viable candidate. But I think the key, again, is as long as it's a group decision, it's a multidisciplinary group decision. There's not one, you're not driving, let me do it first, let me get in there with my stent first, why don't you wait, let me do it first, but it's a group decision. I think the outcomes, you just have to kind of go with the flow, and as the patient changes, adjust your approach. We, just before we came, had a patient who sat in another hospital for 3 days, getting all sorts of workup, and by the time they're transferred in, and then we didn't have a bed, and by the time they're transferred in, they went to palliative care. But, we had a whole sort of multidisciplinary plan set up, but things just changed by the time they got to us. So I know it's frustrating, but I'm not sure how you deal with that. Maybe our surgical colleague can speak to that.
Yeah, well, I think if the patient, if you think that the bowel might be compromised, you have to go and have a look, whatever method you prefer, but you need to have a look, because what's making the patient unwell is actually the sepsis because of the transmural ischemia. So if you don't remove that, source, the patient would never get better. So you might decide then not to go in the therapeutic route. That's another option. But as I said, there's not a lot of literature on how you based your decision. But we get a lot of support from the intensivist, like in the ITU, because they might use other things, to prognosticate. But based just on the bowel ischemia alone, it's kind of hard to make that. But I would, as a surgeon, we would tend to go and try to have a look as much as possible. It's like we would never try to hold the patient for that. Because most of the times, what we do, if it's too extensive, is open and close. But at least okay, what's happening.
So there are lots of different techniques for recanalization of acute mesenteric ischemia, and we've had quite a few questions on the app about what are the panel's preferred methods. So really this relates to the interventional radiologist. But what are your preferred methods for, achieving recanalization? Do you use stents? Do you use suction thrombectomy? Is there a role for a stent retriever?
Or a covered stent if you're just stenting away thrombus.
As with stroke treatment, large bore suction thrombectomy has a very good role in getting a lot of embolic material out of the mesenteric vasculature, and then, of course, stenting of the origin of the proximal part of the superior mesenteric artery.
looking on the latest literature, it is a lot of devices which are now used in interventional radiology procedures, and quite a number of them actually are transferred from other treatments which are used for other occlusions, and it is already what you have mentioned about stroke treatment. So even in some papers you can read that solitaire devices which are used for stroke or other mechanical retrievers are used to remove emboli from the mesenteric artery. So I think that it varies very much on the experience of the center, particularly that quite good results were presented from, for example, use of solitaire to remove the clot from the mesenteric artery.
Like to get it done as quickly as possible. So, and it's simply, so usually an aspiration catheter, 7 or 8 French. Those deflecting morphable sheaths are very effective in positioning you to get good access. More recently, we've been using CAT8's, penumbra system, which you have a more mechanical. And if there's anything residual, a stent, covered stent, just in general, just stenting thrombus alone, I think our experiences with that have been less than satisfactory in terms of squeezing thrombus just distally down. So usually try and clear out as much as possible. Very reluctant to run a lytic catheter in these patients. After that, it's reperfusion and then usually some kind of direct evaluation of the bowel. But we have on occasion run thrombolytic catheters for a while after clearing out as much as we can.
Another question that's come up that might be interesting to do a poll of the audience. If we could just get a raise of hands as to how many people have placed a SMA stent for acute mesenteric ischemia. Okay, and of those, how many would prefer to use a balloon expandable stent as your first choice? And of those who first showed their hands, how many would prefer a self-expanding stent? I think the balloon expandable stents outnumber those for the self-expanding stents. John, just to follow up on your last comment, there was also a question about specific deflectable sheaths and which particular vendors that you have a favorable experience with those devices.
Yeah, I have no connection to any of the vendors. There are multiple vendors have them. I think ours is an Oscor, which is just the one that we ended up with. So
the Destino?
Yeah, so there's Destino sheaths. I mean, there's just a bunch of vendors that have sheaths. You can probably go out there and see them. So, but I would just look for, in there, a variety of sizes, but maybe something that's 65 or less in length because you want to be able to put diagnostic catheters through. So we usually use a 55 or 50 length.
And a question regarding the follow-up imaging. There's a question about CTA and ultrasound. So if a patient has a stent that you can't, for example, see very well into the stent because of overlying calcification, etc., would you recommend a CTA yearly? Would you just look at an arterial phase only? Or would you also consider doing a portal venous or even a non-contrast?
If I have confidence in my colleagues doing ultrasound, then this is usually enough to look for restenosis. Prior to treatment, I would like a CTA. But just for searching for restenosis, if the conditions are good, ultrasound is surely the way to go in a compromised cohort of patients with reduced renal function and so on.
Do you think there's a role for dual energy CT in diagnosing acute mesenteric ischemia? Because there's been a lot of push to do what we call a virtual non-contrast CT scan to try to reduce radiation dose. Or do you think that the technology is not good enough and that we should still be doing a triple phase CT scan?
Kind of CT scan?
The question was, with dual bolus energy CT, sometimes we can get away not doing a non-contrast CT scan. Do you think the technology is good enough to be able to do that, or do you still recommend that we should do a non-contrast CT scan and then still follow with an arterial and then a portal venous phase?
Since the clinical condition of this patient is really compromised, it's really difficult to use any kind of oral contrast. That's why most of our colleagues and the recommendations they do not suggest any use of any oral contrast and even neutral contrast. Is that what your question?
It was more of around the dual energy CT scan where they can subtract the iodine from the arterial.
There are some papers about the dual CT, but nothing has changed much at the moment.
A couple of questions have come in related to reperfusion syndrome. That, you know, this is certainly well recognized, say, in the lungs, where if you do endovascular or surgical thrombectomy for chronic pulmonary embolism, you can have a significant proportion of reperfusion. Has this been something that people have seen after a successful endovascular or surgical revascularization, subsequent reperfusion injury to the bowel when a patient goes back for second or third look laparotomy?
In the surgery, we see that in the first one. The second look laparotomy, we normally leave it for management of the bowel, further resection, and deciding of we're closing or doing anastomosis. But it's something that we normally are very concerned, and we alert the anesthetist about the time that we're reperfusing, because it's something that we've seen, but it's on the first intervention most of the times.
And what are the direct manifestations that you see surgically with the bowel that alerts you that this is reperfusion injury?
Reperfusion syndrome, we normally are alerting more the anesthetist because it's more having like arrhythmias and other kind of a, you know, like having back on the flow, the ischemia. We're reperfusing the ischemic bowel, so yeah.
Okay.
Okay, I guess if there are no more questions, I'd like to thank all our speakers very much for the excellent presentations, and I wish everyone a good day. Thank you.